Good morning. It is May 27th, 2025. I will call the Board of Health meeting to order. Present, we have board members Frank Ehrlich, Ken Lalim, Anthony Santella, and Joan McNeil. We also have Health Department staff members Daniela Fignon, Teresa Argandesi, and Brian Weeks, and myself, Deanna Diamore. The first item on the agenda is the acceptance of the minutes for the regular meeting of April 22nd, 2025. Do I have a motion? Accept the minutes?
Moved.
All right, I think Frank first and then Anthony second. Do we have any edits or discussion on the minutes? All right. Hearing none, I'll call for a vote. All those in favor of approving the minutes, say aye.
Aye.
Any opposed? Any abstentions? All right, they pass. Thank you, everybody. Next item on the agenda is public participation. I see we have an attendee with their hand up. Daniela, do you see?
Yes, it is Diane Loricella, and I am going to allow to talk.
Good morning, Ms. Loricella. Just a reminder, 3 minutes and related to an item on the agenda. Good morning. You may begin.
Yes, good morning, everyone. Diane Loricella, 21 Little Fox Lane. I wanted to just ask, when I spoke at the last meeting, I had requested my concern about when under the director's comments, I of course don't know what will be spoken about, but I have not heard back from anyone related to the health department's role in reviewing the health threats to children and participants on artificial turf fields. So aside from this meeting, Deanna or anyone on the staff or in the board, could someone please get in touch with me so we could have a civil discussion about my concerns and the true concerns about artificial turf fields? We have 6 in the town, and there is a new one proposed at Broad River Sports Complex. So this is a health issue as well as a sports issue. So could you please let me know? You have my email address. I'm always willing to talk. Deanna Diamore, Director of Health. Could someone please get in touch with me later? Thank you.
Thanks, Ms. Loricella. I'm assuming that's it. And I don't think I see anybody else. All right. Next item on the agenda is the Health Department brand guide. Teresa is going to give a presentation and discuss this. So I'm going to pass it on to you, Teresa.
Thanks, Deanna. I'm going to try to share my screen. Okay, maybe I'm unfrozen now. Let's see if I can move into presentation mode. There we go. Are you guys seeing the slides in presentation mode?
Yes.
Okay, great. Thank you so much. Good morning, everybody. It's great to see everybody. Hope everyone had a good weekend. I just wanted to talk a little bit about our branding update. The health department has an existing brand guide that was established in 2019, and we were looking to bring a group of staff members together to talk about, what parts of that guide are relevant and what parts need to be updated. So we'll talk a little bit about that now. So the first question is, what is a brand? So we found some great examples of quotes out there mostly in the business world to try to describe what a brand is or what branding is. And so if you look in this top left-hand corner, brand is a holistic sum of customers' experiences composed of visual, tonal, and behavioral brand components, many of which are shaped by interactive design, which is a long and maybe more complex way to describe it. Whereas in the top right-hand corner, in more layman's terms, your brand is what people say about you when you're not in the room. And so we've talked a little bit about with our staff about brands and how they evoke an emotion usually. And so it's not necessarily the products we are selling or promoting to the public or the services that we provide to the public. It's more about the emotions that people feel or the thoughts that they have about the health department in general, right? And how we can try to shape that emotion and put forth the emotions we want people to feel. So we found some examples of different brands out there on the internet, and brands are more than a logo, but often that's the quickest way to visualize a brand is their logo. And so we talked a little bit about what emotions pop up when we look at these logos, what qualities we associate when we think of these brands. And so, some brands evoke comfort, right? Others are kind of energizing. Some brands make us think of cutting edge innovation, and others are more, your tried and true, old, reliable, consistent friend, right? So the process of branding is the process of coming up with a brand is asking a question, what perceptions do we want people to have of the health department? What emotions do we want them to feel when they think of the health department or see our logo? How are we recognizable to the general public and lots of other stakeholders as well? So a brand is that personality. It's how our audiences or our stakeholders relate to us, to our programs and services. And so, like I said, we think a lot about the logo when we think of a brand. The colors associated with a brand, what fonts they use. Those are probably sometimes the most recognizable pieces of a brand, but it also includes content, right? So a company or an organization's vision, mission, values, their tagline, their key messages. And then there's themes, right? And these might not be explicitly stated, but these are themes or elements or qualities that we want to be running in the background of everything, of all the communications that we put out. So that could be things that are communicated in print materials like our brochures and our flyers and our online content, but also in how we interact with clients and other stakeholders. And the interesting thing about a brand is that it's completely defined by others' perceptions. So we could create a brand guide for the health department that describes our brand in one way, but if other people see the health department in another way, that's our brand, right? So we're trying to shape the content of our communications and of our customer experiences in a way that evokes the brand that we want, that we believe is important for the health department to have, but it really is reliant on how other people perceive us. So branding is important for a few different reasons. I remember in 2018 and 2019 when we were creating our first brand guide, we did take a long time to talk about that we are not a for-profit company that is, is trying to sell products or find a differentiation or an edge over a competitor in the marketplace in most ways. But our organization, it's still really important for us to have a brand. So branding raises awareness about all of the great work that we do at the health department. It helps to foster trust and build credibility. It helps to effectively communicate our value to the community. It helps to differentiate us from other public health agencies and healthcare providers. In our discussions, we did find that there is still a lot of confusion about the role of the health department in the community, and so trying to help people understand those differences. Branding helps unite our many offerings under one theme, right? So the health department does so many different things, and they can be very different kinds of programs and services for the community. So to be able to unite all of those things, from environmental health to biostatistics to health promotion under one umbrella and one unified theme, is really helpful. And then also it helps to reinforce the identity of public health across the whole country. So not just our local health. So as I mentioned earlier this year, we pulled together a group of staff members who volunteered, who were interested in spending their time on this work. We had four pretty brief meetings. We had really efficient and great conversations. We had 11 staff members participate from many different divisions throughout the department. And we had great discussion about the current perception of the health department in the public, common misconceptions that we hear out in the community, changes and trends locally and nationally since the last time we went through this exercise in 2019, and who our key audiences and messages would be. So let's start with the nuts and bolts, the brand elements. So these are important for consistency and visibility. So really, we want, when someone picks up one of our materials from a brochure rack, or they see us in the community, or they're at a health fair and there's 25 different vendors, that we're easily recognizable, that they know when something is coming from the health department, when it's a staff member from the health department. That increases our visibility and the consistency that we have. And that helps to foster trust, so that people know where we are, what we do, that we're out in the community, and that we're here for them if they need to reach out. And so the most prominent brand element is our logo. And so we have several versions of our logo, and we've outlined in the brand guide how to use the logos. And so ideally, I've listed them here in order of priority, right? So ideally, we'd like a tri-branded logo, like you see in the bottom right-hand corner of all of these slides. And so that includes the City of Norwalk's logo, the Public Health national logo with the Norwalk Health Department name on it, and our FAB seal to show folks that we're accredited. But we recognize that those three logos side by side in that way might not fit everywhere. It might not be appropriate, or from a design or format standpoint, it might not be possible. So then the next best thing is the co-branded logo with the City of Norwalk and the Health Department logo side by side. And then at the very least, minimum would be the navy and gold public health seal that you see from other health departments around the country, with the Norwalk Health Department on there. So we want to include as many of the three logos as we can fit on that, in a way that is that meets the design specifications of those logos, but recognizing that the shape and the color design might not work for everything. So just having multiple options for things. And then the colors associated with all of those logos and the fonts associated with all of those logos are included in brand guides that we have saved on the health department server, so people can go and take a look. Believe it or not, most brand guides do have a recommended font to be used that matches the logo or matches the brand identity that the organizations have put together. And so the City of Norwalk's I Love Norwalk brand guide does have preferred fonts, and the NACCHO Public Health Brand Guide also lists those out as well. So those are some of the visual elements, but we spent most of our time, because those visual elements aren't changing much. We're not rebranding or changing our logo, but most of the conversation in our work group was about, how do we really want people in the public to see us? What are the themes or the personality or the identity and the tone that we want to set with our communications? And so as part of that discussion, these are some of the main themes that we came up with, and the group kind of vetted and talked through. And so the first one was that we want to be seen as trustworthy, that we're knowledgeable, that we're honest, that the health and safety of our community is our #1 priority. We also talked a lot about how we do want, we feel like people recognize us as being a kind and compassionate organization, that we're friendly, that people get good customer service, and that we're a safe space and non-judgmental, meaning that, you know, people can feel free to share their thoughts, their opinions, ask questions they might not be comfortable asking in other places, or come to us for services that they might be scared to seek elsewhere. Moving then again, you know, to the right, there was a lot of discussion about showing how vital and valuable we are to the community, and really describing what a wide range of services we offer. The group also talked about communicating our high quality, whether it's about us being accredited or just the fact that we work to maintain best practices throughout the department, and that our staff is well trained and experts in the field. There was a discussion about efficiency too, to make sure that people recognize that we're a resourceful group and that we try as much as we can to connect people to services and information that they need, even sometimes when it's about connecting them to outside agencies that support us and partner with us, and that we're dedicated and reliable. And then finally, we did talk a lot about being community minded, that many of our staff members live here in Norwalk, that we're dedicated and consider ourselves to be part of this community, and that we partner really a lot and value our partnerships with external partners, whether they're other folks within the city, or outside nonprofit agencies, healthcare providers. You all know we talk a lot about those partnerships, and we really wanted to call that out as one of our themes. So for those of you that don't remember our brand guide from 6 or 7 years ago in great detail, these themes are pretty similar to what we talked about in 2019. I think maybe one of the differences is that the trustworthiness and safety seem to really emerge as the most important things that the staff and our work group consider to be important for us to communicate. So in 2019, the emphasis was really on quality and expertise. And I think a lot of things in the last several years have shifted, so that we really want to make sure that we're strengthening that trustworthiness and that fact that we are a safe place for people. So in 2019, the brand themes were expertise, caring, community conveners, nationally accredited, and then one on regulation through relationships. So talking a little bit about how, as we regulate, we're trying to build relationships, provide education, and work with the agencies or the organizations that we regulate. And so I think a lot of that is also represented in these themes as well. And then the final area that we talked about that is an important part of the brand guide is our key audiences and the key messages that we have for each. And so you can see some of these, some of the different stakeholders and audiences for our communication that are listed here. The general public is the largest one and has the longest list of key messages, but then you can see that there's other audiences that may have that need to hear those same key messages that the general public would about our overall programs and services and our mission and vision, but may have some specific messaging that is unique to their sector. And so again, these are very similar audiences that we identified in 2019. A couple updates: faith-based organizations and public schools had previously been included under other community-based organizations, but the group felt like it was important to pull them out and name them separately, because there might be specific messages for those key audiences that wouldn't fall under the larger umbrella. We did add youth to this list, which was not part of our list in 2019. And the work group had a great recommendation to include volunteers in the stakeholder group with our health department staff. So our next steps with this, I just want to thank the members of the work group. They did such a great job. You know, this is outside of our comfort zone in public health in terms of trying to kind of learn a little bit about what branding is and why it's important. And they They contributed such incredible insight and perspective. And so we're pulling all of this information into a brand guide with real specifics about the way to use the logo and a more fleshed out definition of what some of those themes might mean. So we want to finalize that, get the work group to read through it, make sure that everything was captured. Then once the brand guide is complete, we'll update any other related policies and procedures. We have an external communications policy that will likely need a little bit of an update as a result. And there may be some other policies and procedures as well. We'll work to train the whole staff on the brand guide. And then start wherever we haven't already. A lot of this we have started to incorporate, but incorporating the brand guidelines into our communication materials, promotional assets like uniforms, tablecloths, banners, those kinds of things, and our in-person communication. So the Community Health Division manages a lot of the external communications in terms of the website and social media and graphics and brochures and that sort of thing. But every single staff member has a role to play in communicating this brand in their in-person interactions with different stakeholders. And then the other area we want to look at is ways that we might be able to evaluate this work. Is there a way to measure success in terms of how well we incorporate the guidelines, and then also, what outcomes those guidelines bring to us in terms of building trust and communicating more clearly to all of our different key audiences. And so that's our update on that. And I can stop sharing and see if anyone has any questions.
It's not a question, it's more a comment. First of all, thank you for sharing that. I know this is one of those things that's not always on the top of everyone's radar, but very important. So I can appreciate all the work that you guys did to do this. Because as you can imagine, where I work, they're kind of over the top, and I'd say slightly obsessed with branding and using the right PowerPoint template and letterhead and this, that, and the other thing. But one of the things that they've asked us to do, and I think most people do this because it's not a big deal, is they've incorporated the branding and the colors and things like that into the email signature. And so everyone basically has the same email signature, and they to kind of nudge people along, they cited something, I'm going to get this wrong, but something like, I don't know, there are 10,000 emails sent by university employees each day. And so the more, and that's people from the outside and inside kind of reading things. And so the more you can kind of weave in the branding into the emails, since we rely so much on emails, the more you're pushing it out. People know the color, people know the font, people know this. So it might be something to keep in mind if you guys aren't doing that.
That's great. That's a great suggestion. Thank you.
Thanks for the presentation. That was great. I'm glad that kind of stuff continues to evolve. I can take it back a little bit of history in the I think 10 to 15 year time frame in the rear. When we went out to potentially change the structure of the health department and where it fit into a regional program, we encountered opportunities, I'll call it, with the general public not understanding what public health is. And I don't know that I see it directly in here. I don't know if there's a place for the continued education of the general public with all the different changes that are happening as we live through some of those. But that education about what public health is probably is a very important step to using all these activities that we have and programs that we put forward.
Thanks, Ken. That's a great suggestion. And we did have a lot of discussion about that, both on the macro level and then also on the micro level in terms of like locally also, what does your public health department do and what do we not do, and how can we, how do we work together with other folks? And so you're absolutely right. We did talk about that a lot. And the good news is there is more and more resources and toolkits and guides from our national partners, whether it's DBOMA or NACCHO, to help us get that messaging out. So that's really helpful. Thank you.
I see Joan's hand is raised.
Teresa, I just have a question. Great job and on a very important topic. How did you measure public perception? I was curious about, and I noticed you said it in the discussions.
You know, we actually were taking the opinions and perspectives of our staff members in terms of when they're interacting with the public or when they're seeing feedback, whether it's, you know, formal feedback or informal feedback that they get from individuals they're working with in the field. Here are some of the areas where they're still seeing misconceptions, and where they do feel like they've gotten good feedback, right? So we went through this exercise. How do we feel like that the public sees us now? How do we want them to see us? And what misperceptions are we hearing out there that are incorrect that we definitely want to clarify and address? And so that was really just the opinions of the staff members in the work group.
Okay, all right, okay. Do you get a lot of traction on social media? I was just curious.
Yes, you know, more and more. We're very fortunate. We have great partners at the mayor's office who work in communications who are able to amplify a lot of our messages. But we did see a huge increase in the number of followers that we have on social media during the pandemic. And a lot of them have stayed with us and continue to engage with us. So our reach and our impressions have increased significantly in the last few years. And now we're able to leverage that to hopefully be able to communicate some more non-emergency messaging.
Okay, all right, great job. Yeah, thank you.
Teresa, that was an excellent presentation about a very important subject. My only comment is, having been in healthcare now for almost 60 years, the one part about creating a brand that differs from Apple and Coca-Cola and a lot of the brands that we know and see every day is that the consumer, the public, doesn't understand a lot of what healthcare is. And when we talk about healthcare, it's way over their head. They just don't have a grasp. It's not a fault. It's not a lack of education. It's just something they don't understand. As a side comment to that, not that many of us who provide it truly understand it. So one of the issues in creating a brand is how to create something that the public will want to look at and look into further when they don't understand it. We turn off when someone says something that I don't understand. So you really have your hands full, my dear.
Yes, that's it. No, that's a great point. And you know, it's so interesting. And it's kind of, I think, a little bit connected to Ken's comment too about just general description of public health. Part of I think it was the first meeting we talked about, okay, what do we do? You know, first before we tell everybody why it's better than, you know, than they might think it is or how we do it, we want to define what we do. And we talked and talked, and it was all jargon, right? I said, okay, but what does someone who doesn't understand the health department, what do they think promote the health and well-being through information provision? You know, like when we start to talk in more concrete terms, we offer this service, we offer this service, we provide this, we connect people in this way, and talk in more plain language. I think you're right that it will resonate more with people. And so that's actually part of the next phase, as we figure out how to incorporate these brand guidelines. It doesn't help us to communicate in a caring way if people don't understand what we're talking about. So we want to make sure that both the tone and the content are clear and communicate the brand guidelines. So that's a really important point. So thank you so much.
One of the sidelines to that is, if you look at Coca-Cola, a big part of their brand creation was burying Pepsi-Cola. We can't bury our competition. We have to promote our competition, hoping they will promote us as well.
Yeah.
It totally eliminates a big aspect of what a brand is and how you make it work.
Well, this is great discussion and a great presentation, Teresa, and really great work that you're leading with the work group. So thank you. Any other comments? All right, thank you, everybody. Next item on the agenda is the flu clinic QI storyboard. And y'all are you able to give us an update?
Absolutely. All right, I am going to share my screen. Excited to be sharing the final storyboard product with everybody. This came out of the flu clinic QI, or quality improvement project, that we worked on basically from February of 2024 all the way through February of this year, and continue to work on in some different ways. So just a basic introduction to the project. You guys may have been familiar with it. I know that we've talked about these kinds of things, you know, in shorter terms and other meetings. You guys have had an opportunity to come to some of our clinics and engage with our staff. But what we did here was to focus our quality improvement on the flu clinic program that we have here at the health department. So I'm going to talk a little bit about quality improvement in general, just a little refresher. You know, quality improvement is taking a look at, you know, how we can improve a service or a process, sorry, not a service, a process. And in this particular case, it's a service and a program, but we wanted to look at very specific processes. And so we had a very specific formula for doing this. We used the Plan, Do, Study, Act model, where you effectively, you know, hypothesize some sort of idea. You test the idea, and then you collect data on it and make an informed decision about how to move forward. So the first part that we started with was identifying an opportunity. So back in February of last year, we got together as a flu vaccine planning team, which we do on a regular basis, and talked about some of the issues that we had experienced with inconsistency and unpredictable attendance by the public at our different flu clinics. There was a lot of uncertainty about whether that inconsistent turnout was influenced by barriers to accessing the flu program, whether there was insufficient publicization of the program, or if there's just a general decline in flu vaccine uptake. The other issue that we really wanted to focus on was consistency and operationalization of the actual flu program when it's in action. So, you know, we have staff and volunteers who work with us on an annual basis to staff these clinics. And we've had a little bit of inconsistency from year to year and from clinic to clinic. So, you know, what we've seen is that we've typically titrated each clinic based on the needs of, you know, what's coming up. But we didn't have anything written out formally of, you know, how are we going to manage clinics in general. So we pulled together a team, and it represented almost all of our office. So we had administration and operations, folks from community health, folks from epidemiology and informatics, our emergency preparedness division, preventable diseases, and our office of the director. We also had a couple of emergency response team members pitch in to the project, as well as obviously staffing those clinics and providing feedback. So what we worked on first was to come up with an aim statement or a goal. And so sometimes with these aim statements, we retrofit them. And so that's what we ended up doing here a little bit. You know, as you go through the project, you know, you realize that sometimes the goals you had in mind for the particular process improvement might not actually be the thing that you end up working on. So what we found, you know, when we did all of this work, was that we wanted to, by January of this past year, we wanted to increase flu vaccine uptake by 2% from the previous year. So that was the 2023-24 year. and collect data from at least 50% of community flu clinic clients to identify advertising methods with the most reach. And we also wanted to develop one written standard operating procedure SOP for community clinics. So those are our larger mass scale clinics that we offer typically, sometimes outside of office hours or on a large scale basis. Sometimes we do them out in community sites, but those community clinics are more flexible clinics. And we also wanted to, provide an SOP for our worksite clinics so that we are improving and standardizing really the delivery of all of our services, whether that's, the flu program at a community clinic that's in the health department, whether that's a flu clinic that's at a worksite out in the community or elsewhere. So all these deliverables were crafted to inform and optimize our planning and execution of the flu vaccination program in future years. We had our scope limited to last year's flu season, so that ran pretty much between October and December. We do, administer flu shots beyond that, but we needed a time frame to limit our scope to. So we started to collect data and examine our current status and see where we actually were. First, we started with the electronic health record and identified low vaccine uptake and a recent further decline in the health department's flu program attendance. We used a fishbone diagram, which is a neat little quality improvement tool to elicit all root causes for inconsistent attendance. So it's a little small on the screen right now, but effectively a fishbone diagram puts the problem at the head of the fish. And then you have all these sort of buckets of issues that, might prevent people from or might be contributing to this low attendance at our flu clinics. And then there are all of the different sub-problems. And so what we did was we identified those two sub-problems that we wanted to work on. So the written SOP or, having some consistent operationalization materials, and also that publicization piece. We did that by using a prioritization matrix and pick charts to narrow our focus because there were just so many areas that we could have focused on. And we identified our issues with operationalizing the program and what was needed really in an SOP through staff feedback. They really specifically requested that written SOP guidance to improve the program consistency and quality. So our deliverable came straight from staff on that front. We worked on identifying potential solutions and we came up with a flu vaccine program campaign using various methods of advertising, and then the creation of a flu program SOP as our two deliverables to meet these two needs. We developed our improvement theory, which was that by using multiple advertising methods, the health department would be able to increase the number of clients receiving flu vaccinations. Additionally, a comprehensive SOP will improve program management and standardize the delivery of services. And we tested that improvement theory. So, we worked with Daydream Communications on local advertising and a regional Get Vaccinated CT initiative to create and roll out flu campaign materials. They really spanned the gamut in terms of, types of advertisements. So we had bus ads, billboards, TV and radio media, newspaper banner ads. Banners that were actually on online for the newspaper, and then stickers that actually went on the physical newspaper. We had ready to go social media ads and posts that were deployed throughout the season. And our in-house advertising efforts included postcards to our clients, community newsletters, information on the city website, emails, lawn signs, and those social media posts. Our clinics were operated using a standardized flow. So, basically putting together a draft SOP. And staffing roles were standardized across 2 community clinics and regular weekly in-house clinics. So we did this having 2 community clinics, one in the evening, one during the day, and our regular in-house clinics for those 3 months. And we worked on collecting data to see how that all panned out. So after holding those community clinics, we asked each client if they would like to respond to an optional survey to elicit some information about which advertising methods were most impactful in driving the public to access flu immunization. So, we had some questions on there. Where did you hear about us? Was it a newsletter? If so, is there any specific information about that you wanted to share? And we pulled attendance data from the electronic health record to gauge if the flu vaccine campaign and ads for the clinic had a significant impact on the number of clients at community and in-house clinics compared to recent years. The success of our standardized flu clinic workflows and roles was measured qualitatively in a project team discussion following the flu clinic season. So a lot of qualitative feedback from our staff, where we had open feedback, we had specific questions, and really just tried to drill down to whether or not the SOP was effective. And so our outcomes were really positive. So first up, the most successful communication strategies for driving attendance to our flu clinics were identified as free and low-cost options, which is really, really great. So that's email, newsletters, website banners, and social media posts with boosts. So that came from the surveys that we administered optionally to those clients who came through our community clinics. So that was great. We also found out that traditional postcard reminders were really helpful. So those are the postcards that we send out to clients that have been our clients in the past. It's really just kind of a reminder system. The only thing that we did notice is that attendance didn't increase as desired. So we'll talk about that in just a little bit. The other outcome that we ended up with was that an SOP was successfully developed to be implemented systematically at all of our flu clinics, specifically our community clinics, our in-house clinics, and our worksite clinics, just as we talked about in the AIM statement. And then lastly, we were in the ACT phase. So actually figuring out what we wanted to do with all of the information from this study. So what we decided to do was standardize the improvement because they were both successful. So flu vaccine clinic advertising efforts will be limited to the most effective methods. Again, those free and low cost options and those postcards that we've been doing on a regular basis for years and years now, which is really great to know in terms of funding and where we should be, putting all of our energy. We also developed that final SOP with visual layouts for each type of clinic, which was really, really helpful, because a lot of our staff were visual and wanted to know, okay, where exactly am I standing? What exactly is the route that I'm supposed to be taking when I'm guiding a client from this, from the beginning of the line to a room for vaccination, things like that. And that was really, really helpful for use in planning and operationalizing the flu program. And then the last thing that we did was to decide on future plans. So how do we want to continue looking at our flu program and assessing its success? So we got together, we talked about what we wanted to do, and we said that we want to revisit some of the adjacent issues identified in the flu program through some of that staff feedback and some of the surveys. And what we want to do is conduct some rapid cycles. So those are mini QI projects where you get to take a look at like one really small aspect of the program or system and identify issues with that process and work on it in a smaller time frame. We're thinking about using the EHR, our electronic health record, to better track demographic data to inform targeted advertising and practices. Just trying to make sure that we are as targeted and as helpful as we can possibly be to the community. And the other thing that we want to do is to monitor trends in vaccine hesitancy and continue to deliver flu vaccination services in accessible ways. So as many of you know, the attitude towards vaccine uptake has really changed over the last 5 years. And so we're seeing a lot of burnout from the community on vaccines, and we want to make sure that we are addressing that in a way that gets people in the door to get vaccinated for all of these preventable and communicable diseases. And so with that, I will stop sharing the screen and see if there are any questions.
I had a quick question. Hi. Thank you for sharing this. This is a lot of work, so I can see it just in this one slide, and I'm sure you all have spent many, many, many hours doing this. Sorry if I missed this, but what leads you to think the communication strategies kind of on the top right there are the most successful if it didn't yield more people coming to the clinics?
Right. So we were looking at which are the most successful in terms of just like getting people in the door, not like the number of people that were coming in. So, where are people hearing about this flu program? not necessarily thinking about just the number, but who is coming to these flu clinics.
Right.
And so with the surveys that we administered to clients afterwards, they had a couple of options. They could take the first piece of the survey in person on paper or electronically right on site. They could also fill out a survey that was electronic later at their own convenience. And then there was also a second part of the survey for anybody who wanted to provide additional information about why they chose the health department over other places to get their vaccinations. And so we really elicited that information directly from survey responses.
Mm-hmm. And then, thank you. And then my second question is, do you ever collect information from the non-responders or the people, who decline?
So it was a completely voluntary survey. We did not want to make anybody feel, we didn't want to contribute to the vaccine hesitancy or the uptake issues that we have seen. So no, it was optional. There have definitely been other programs or initiatives where, yes, there is more follow-up to see if people are more willing to respond at a later time. But for this particular program, we just left it to voluntary participation.
Mm-hmm. Okay, thank you.
Daniela, that was an amazing amount of work and an amazing presentation. My comment isn't really related to your work or the studies you've done and the outcomes you have. It's more a comment on what I regard as a national issue. With all the anti-vaccine talk that's going on, I don't see anyone explaining to the public how vaccines work. Why should they believe vaccines are effective and don't cause the issues that they've been accused of causing if they have no understanding of what a vaccine is and how it works? It's just not part of the public information. I would be willing to bet if you interviewed 100 people in the high 90s, unless you happen to do it on the Fairfield campus, where I suspect there are a lot of people who understand vaccines. But Main Street in Norwalk, I'll bet it's close to zero. And why do we expect them to believe in vaccines and their effectiveness if they don't understand how they work?
That is a great comment, and I can absolutely see, where that might get some traction. And I'd love to invite you to chat with me further on this. I'd like to, see if this is something that we might be able to consider in our future rapid cycles to see if there's anything we can do around this. So thank you, Frank. That's a really wonderful idea.
Well, thank you, Aniela. Thanks, board members, for your questions and comments. Great job to the team, the extensive team who helped put that together. Thanks, Aniela. All right. And now we have epidemiology updates from Brian. Gonna pass it on to you, Brian.
Hey, good morning. Thank you, Deanna. Good morning, board. Good morning, everybody. All right, so I'm going to try to do this quickly, but there's a decent amount of content, but I'll try to be as concise as possible. And obviously you get me speaking very quickly too. But with that said, so this is the CDC community snapshot relative to respiratory viruses. The point here is, again, we're looking at Connecticut, the overall respiratory illness activity. It's very low, which is great. And so overall, everything for emergency department visits as well as wastewater viral activity is at low or very low. And you can see the trends are decreasing relative to these ED visits for the big three, so COVID, flu, and RSV. So good news. And so in which case, I'm going to jump over to this graphic. This is the emergency department visits for the big three for the state of Connecticut. And you can see that proportion of those emergency department visits for all three are low again, further confirming that. But this is just a nice visual to actually see it and where we're at. And so again, generally speaking, looking at it from a hindsight perspective relative to the season, You can see how we kind of peaked around, the January, December area. And especially this season was really driven by influenza. As you can see here, its peak much larger in comparison to the other two. And obviously we were kind of familiar with that too. So we lucked out in the sense that we didn't have a massive peak relative to COVID-19. But it did carry throughout the season. But flu definitely had a very steep peak, as we can see here again back in January. And then RSV was still pretty low in comparison. It didn't kind of have that massive comeback like we saw back a couple of years ago, in terms of when everybody started, switching from masking back to kind of normal standards of normal life, where it had a resurgence. That immune debt, as the kind of phrasing came from that. So overall, pretty good. And I just want to kind of again look at it in hindsight now, zooming again back to COVID. Kind of what we dealt with for the season. And as you can see here, about almost 3/4 or about 70% of the proportion of the Omicron subvariants that have been circulating for this season, it's the LP.8.1. So the reason I just mentioned this is, again, it was the primary driver of COVID for this current part of the season. It's currently what we're still dealing with. This is looking at, again, from a national scale. And so likely this is, as we look to the future, as we were talking about vaccinations, this is likely the variant that will be kind of used as the reference for that future development of the vaccine. Again, we're dealing with a very unique time now in terms of what the future holds for the COVID vaccine and the recommendations. But regardless, I just wanted to put this on everybody's radar. What we've been dealing with is the LP.8.1, which is a subvariant that's part of the parental lineage that included the JN1, BA.2.86. A bunch of others. So it's going to have at least the ability to track back if some of those others resurge, those prior subvariants that we were dealing with. It has close linkages to it. But then, as we're familiar with every season, it further develops, new spike proteins develop or are removed from the virus. So it's going to be something related to LP.8.1 in the future. Just based upon what we're seeing right here. I just want to kind of emphasize that point. I just thought it was interesting. I just want to keep everybody up to date relative to that. With that said, even though we're getting to the better weather, as we've been seeing over the months, rhinovirus and enteroviruses still are kind of the primary virus, part of the NRE VSS surveillance on a national scale. We see human metapneumovirus kind of hesitating there, so it's not going up as much as it was in the prior weeks. We do see parainfluenza virus kind of kicking up a little bit, but it's again par for the course for these two viruses. So it's just something else that we just need to keep in mind. We are dealing with respiratory viruses circulating, even with the slightly better weather, even though things have cooled off a little bit. So I wanted to just mention that. And again, taking those proper precautions there relative to, just mitigating the spread of those viruses, as we've kind of seen and talked about many a time. So with that said, we also have kind of our gray area with, it's allergy season. So I'm just sharing from pollen.com, just kind of what we're dealing with. So just keeping that in the back of our minds, because we have medium high activity today, tomorrow, about the same. And, the top allergens or drivers for that right now is oak and birch trees, along with just grasses. So just anybody, if you know what your allergies are, your triggers are, just if these are there, just taking those proper precautions in terms of managing with antihistamines and things of that nature. So now switching gears to our favorite thing here in terms of measles, just an update there. For the year 2025, the United States is now at 1,046 cases. So we broke the 1,000 mark as we anticipated. So about 67% of that is 19 years of age or younger. 96% of overall the cases is unvaccinated or unknown vaccinated status. 12% resulted in hospitalizations. And so about 30% of those cases, the overall cases, was 19 years of age or younger. This has resulted in 3 confirmed deaths so far in this process. So again, 1,046 we know is a very high number. Well, let's get some more perspective on that. So we'll zoom down a little bit further. Some good news here, and I believe I mentioned it at the last meeting. When you look at it from a weekly case rate or case number by rash onset date, so when the actual, the big concern is with infectiousness, right? When somebody is considered infectious is about 4 days before the rash onset. And so you want to kind of look at it from that perspective, and then about 4 days after the rash onset too. So that kind of contributes to those continual exposures that result in more cases, especially those more susceptible to it that are unvaccinated or have, immunocompromised, immunosuppressed state. Overall, for the recent few weeks, we've been looking at where these weekly counts have been decreasing, which is a good sign where, we see the peak here somewhere around late March. But still, anything's possible. If you've been following the news, there's been concerts, other very large public venues where there have been measles exposures. So this can kind of ramp things up again if it's given the right opportunity and the right settings. Again, a lot of travel happening right now too. So we have our fingers crossed, right? But, we want to just be mindful of the circumstances, but at least this is good news for the moment. And then you look at it from a state perspective for 2025, you can see the epicenter here being Texas. And you can see how, parts of the Midwest, the West Coast, Mid-Atlantic, and even part of the Northeast, kind of, in that mix there. Connecticut, knock on wood, everybody, very fortunately not presenting with any cases at the moment relative to this data collection. Again, the presumption here is maybe there were cases, but they slipped through with mild symptoms, or especially we've been better buffered with our better vaccination uptake relative to our state. So actually, I'll jump to that visual first. So this is looking at for MMR vaccine coverage for kindergartners by school year for 2009 to 2024. This is just estimating, again, the percent vaccinated. So what you really want to have is that blue color. Very fortunately, Connecticut and some neighboring states like New York and Massachusetts and Rhode Island are in that mix. But generally speaking, majority of the country is at that, less than 90% or the low 90th percentile. This gets into that discussion and the debate about herd immunity. The best case is, again, being at 100%, right? That's the best herd immunity you can get, because that also mitigates and get against potential breakthrough cases, varying immunity relative to individual state, right? You have a lot of different things that can affect somebody's immunity. So that really best protects and buffers against further transmission. But regardless, we do have quite a few states, and then consequently the residents that are below that 90th percentile that can contribute to this. Hence why we also see, like with Texas being the epicenter of it, they're in that lower 90th percentile. So they're not even less than 90th based on the data and the estimates here. So you can see kind of how this can kind of keep this going and keep spiraling. Very fortunately in the Northeast, we have a better consensus there, but you can see Vermont and New Hampshire kind of being the exceptions to the rules, and then Pennsylvania and New Jersey also kind of being exceptions there too. And so then jumping back up, looking at it from a yearly case count standpoint, you can see where we're at right now with our 1,046, how we were the previous year at about 285. But then also where we were in 2019. I don't know if you guys recall, right before the pandemic hit, we were experiencing a pretty severe measles outbreak at 1,274 cases. Very fortunately, a silver lining related to the pandemic, given the kind of the shutdowns with travel and as well as the stricter masking, that caused the measles case numbers to really drop off, as we see here in 2020, only 13 being counted. So we really lucked out. Again, cases probably slipped through, but they weren't really traveling much, so it didn't give it a lot of opportunity to spread. But then also we're dealing with kind of the other downside to the pandemic, which is, again, the big debate relative to vaccines. So now we're starting to see our, chickens coming home to roost, as the saying kind of goes, with those that, now made their stance and their decision in terms of vaccines uptake, and not getting them, especially for their children, as well as those that are individuals that are just, still behind relative to their immunization schedule. Now it's creating that susceptibility there too. So there's a pro and a con to this. I just wanted to mention that. And then also give us perspective on where we're at. So definitely very close to where we were back in 2019. And if this outbreak continues for the rest of the year, then we do lose our elimination status that we got and earned and worked very hard towards in the year 2000. So we want to see this outbreak fizzle out. There is some preliminary data indicating that, but anything's possible, given especially a lot of these public venues and opportunities for further transmission. And if those pockets, enable that, and it gets into those pockets, then it's going to keep going. So I just want to give us perspective there. Just a reminder again about the health department's measles webpage. If you have any additional questions and, just anything else that you want to learn about this, by all means, check out this webpage, norwalkt.gov/1822/measles. And so just a couple other reminders, again, switching gears once more. We're looking at vector-borne disease, so a reminder that ticks are out there, especially in this weather. This is good hiking weather. Just be mindful of tall grass and, hiking and brushing against any sort of vegetation, checking oneself, anybody else that's traveling with you, as well as one's pets. Again, I keep re-emphasizing pets, but that's one of the big opportunities for, picking up these ticks and then getting them in the household and then potentially exposing humans, and then further complicating things, and also allowing these rarer ticks that are not native to our area, further increase their spread, and then they cause other complications too, and carry other kinds of diseases as well. So again, check out the our tick web page here. Could just Google Norwalk Health Department ticks, and this will come right up. And there's more information here, as well as our contact number for our clinic to submit, or for our health department to submit the tick specimen. Again, no cost to Norwalk residents, but for non-residents, $15. And then mosquitoes, I just want to put a reminder out there because, next month is when the surveillance will start for that. So I'll be reporting that out. But with that said, mosquitoes still are, active right now. They're just at a lower activity level compared to where we get later in the season. So that also means protection relative to that. So that is, jumping right down from our mosquito webpage here for the health department, what prevention one could do. So really it's a great opportunity to mitigate their spread territorially and geographically. So that means any sort of opportunity for standing water, please remove that, and check on those things like bird baths, changing that out every week is going to be really helpful, really important to reduce their ability to spread territorially, which then complicates things for West Nile virus transmission or Triple E. Triple E, especially coming from the eastern side of the state, from Rhode Island, generally speaking. But then also using the appropriate insect repellents, wearing long sleeve or long leg pants in terms of protecting one's skin so they cannot bite, as well as using screens indoors. So just a lot of great information here, as well as even a video from the health department relative to mosquito management. But I just want to put that reminder out there too, because that's incoming. And we want to mitigate that territory and spread of mosquitoes and their diseases as much as we can. So again, in summary, respiratory virus, season, we're good now, but we have other things that we want to be mindful of. As well as, we got allergy season going on. We got measles still have to keep a very close eye on, and we want to keep this downtrend so far that we're seeing in terms of case numbers going, so we can still maintain our elimination status, as well as protect everybody's health. And then along with that, vector-borne disease in terms of ticks and mosquitoes, just doing our best to manage that, check ourselves, prevent any sort of future transmission of those things, as well as the vectors themselves. So, the ticks and the mosquitoes. So just want to reemphasize that. So that's just the overall update. Thanks, everybody.
Thank you so much, Brian. Great presentation as always. Are there any questions or discussion? All right, I know we're short on time, but I just wanted to, I know we've been talking about all the federal updates, so I just wanted to let you know that, I don't know if you heard, but the judge, remember the clawback of the COVID related funding that we received? We heard that the federal judge has offered a preliminary injunction against it, and so is ordering that the funds be able to be continued and to be used by states and the locals that are part of that that lawsuit, the 22 states. So we received some news from DPH last week, and so working through like what does that mean for us. But that was really great news to hear recently about the judge's decision. So we're still meeting and figuring out what that means for us, but we will keep you posted. But that was really great news to hear. All right, is there anything else before we adjourn today? All right, thank you, everyone. We will adjourn at 9:06 a.m. Have a great day, everybody.
Take care. Bye.
Bye-bye.